Good afternoon, ladies and gentlemen. My name is Mohamed Osman. I'm a senior clinical fellow at Royal Papworth Hospital. First of all, I'd like to thank the SCTS, Egyptian Society of Cardiothoracic Surgery, and Suez Canal University for giving me the opportunity to be here today. My first talk would be about coronary artery disease from the surgical point of view. And later on, and today, we'll have another session about operative aspect of coronary artery bypass graft surgery. I'm very happy to answer any questions after the presentation. I hope both presentation would be useful for people who's going to do the exam. Thank you very much. Hi, everybody. My name is Mohamed Osman. I'm a senior clinical fellow at Royal Papworth Hospital, Cambridge, UK. First of all, I'd like to thank the SCTS, Egyptian Society of Cardiothoracic Surgery, and Suez Canal University for giving me the opportunity to present in this meeting. In this session, I'm going to talk about the coronary artery disease from the surgeon's point of view. I have no conflict of interest. Just to mention that illustrations in this presentation are taken from key questions in cardiac surgery. I'll start my presentation with the pathology of atherosclerosis. Atherosclerosis is a Greek word. Athero means paste and sclerosis means hardened. So the process of atherosclerosis starts with endothelial damage or endothelial dysfunction with a decrease in NO secretions. Then the foam cells, which is a macrophages engulfing lipids, start to invade the vessel. The second stage, or the early lesion, is characterized by formation of the fatty streak. So the fats become also extracellular, and the migration and proliferation of vascular smooth muscle cells. Then the formation of what's called vulnerable plaque. In this stage, there is a thin fibrous cap, which is very liable to rupture and bleeding and overtop thrombosis. The next stage is the advanced lesion or the atheroma, which might be a need for platelets aggregation and thrombus formation. Risk factors for coronary artery disease are classified into modifiable and non-modifiable. The modifiables ones we can control, like diet, smoking, hypertension, dyslipidemia, diabetes, obesity, high calorie intake, physical inactivity, and psychological stress. While the others, we can't control them, as the advanced age, genetic predisposition, family history, and male gender. The clinical picture of coronary artery disease, the classic picture is the angina pectoris, which is defined as a pain caused by myocardial ischemia due to coronary stenosis. And as any ischemia, it's a demand-supply mismatch. This also might be caused by tachycardia, anemia, aortic stenosis, syndrome X, where there's a chest pain, or angina pectoris without any coronary stenosis. Prinzmetal angina also is a cause which is due to coronary spasm. The characters of the angina pectoris is a deep, diffusely distributed central chest pain. So when you ask your patient to point on the pain, he couldn't. The pain is diffusely distributed over the chest. It also not sharp pain, and here we have to be careful differentiating between the sharp and severe pain. Usually it doesn't last long, 1 to 5 minutes, never over an hour. And if it's going to respond to the GTN, the response would be immediate. We have to be very careful in taking history, especially with diabetic patients. So angina might present with dyspnea, fatigue, recurrent belching. That also suggests ischemia. The angina is classified into stable and unstable angina. Stable angina is the pain which comes with effort and released by pain or GTN, and it's predictable. unstable angina, which is increase in frequency or severity, or when the patient has angina at rest. Another term to be aware of is the acute coronary syndrome. Acute coronary syndrome is a term used to describe acute coronary ischemia. It's subdivided into three categories: unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction. For the unstable angina, there is no ST elevation and there is no enzyme rise. This is to differentiate it from the non-STEMI. With the ST elevation myocardial enzymes, you will find both. When the patient is referred to us as a surgeon for a coronary artery bypass graft surgery, we have to be very careful taking a history from the patient. We asked about the recent myocardial infarction, time, how it was managed, and when was the last myocardial infarction. Any previous cardiac or thoracic surgery or chest radiation. We also ask about any condition predisposing to bleeding or any contraindication for anticoagulation. This is going to change our plan, either surgical plan or post-operative plan. Any renal dysfunction, cerebrovascular disease, or carotid bruit should be also investigation. Any electrolyte disturbance that might to predispose for post-operative dysrhythmia also should be included. Infection should be excluded before elective surgeries. Any respiratory dysfunction, and if we need to send the patient for pulmonary function test, we'll do before the surgery. And we have to take careful history to evaluate the availability of conduits for CABG. This history should include any previous varicose surgery or legs surgery. We investigate our patients as a routine preoperative investigation, full blood count, hemoglobin, any anemia should be investigated and treated before the surgery. Any platelets dysfunction or a low platelet count should also be investigated and treated before the surgery. We have to have full clotting screen before the surgery. Kidney and liver function tests are also mandatory. Screening for MRSA is also mandatory before the surgery. In the chest X-ray, we check for cardiomegaly, calcified aorta, or any lung pathology. Please, if you are suspecting a porcelain or calcified aorta, send your patient for a CT scan because that might change your surgical strategy. ECG looking for previous myocardial infarction or any hypertrophy or arrhythmia. Echocardiography is mandatory before coronary artery bypass surgery, and we are going to discuss this in the next slide. So for any patient is going for a coronary artery bypass surgery, we do an echo to check the function, the regional wall motion abnormality, and the valvular lesion. If you have dyskinesia or akinesia, you have to investigate for viability of this segment. And is the patient going to get benefit from the surgery or not? And for the valvular lesion, you have to decide pre-operative, are you going to do something for the valve, or this patient just needs coronary artery bypass graft surgery? We'll go through this in more details in the next slides with the guidelines. Coronary angiogram is one of the most important investigations before coronary artery bypass graft surgery. As a surgeon, we see coronary angiogram very frequently. So I'm just going through understand the coronary angiogram. So there are two angulation, right or left, and cranial or caudal. When we refer to right angulation, right anterior oblique, we mean that the detectors is on the right hand side of the patient. And when we say it's on the left anterior obliques, that means that the detectors is on the left hand side of the patient. Cranial angulation, that means that the detectors are at the patient's head, while caudal, that means that the detectors towards the patient's foot. There are general rules to interpret coronary angiogram. So the left anterior descending artery that the artery that descends toward the apex, usually the longest vessel in the angiogram, and it has septal perforating coming off at 90 degrees. The circumflex artery is the artery which is closest to the thoracic spine and the descending aorta. If the angiogram through his femoral artery, you can see the catheter in the descending aorta. There are 5 standard views to view the left coronary system, and there are 2 standard views for the right coronary system. For the left, right anterior oblique caudal, apicaudal and cranial, left anterior oblique caudal and cranial. For the right system, you have left anterior oblique and right anterior oblique. To identify the angiogram view, there are some rules. Usually the spine is on the opposite side of the view name. For example, if you can see the spine on the left-hand side, so that would be right anterior oblique. Sometimes you couldn't see the spine in the view. In this case, you check for the ribs direction. So the rib directions go from up to down at the same direction of the view. So in the right anterior oblique, you will find the spine on the left-hand side, as here, and the rib direction going to the right-hand side. So this is right anterior oblique view for the left system, which shows the left main, the circumflex artery, and the LAD. This view is good to see the circumflex artery all through. And here the angulation is caudal angulation. So right anterior oblique with caudal angulation. So this is again the left system with the AP view, caudal and cranial. So we can see clearly the left main coronary artery and the LAD going through here with one of the septal perforator branches. And this is the catheter there. Again, that's the catheter, left main, circumflex. Apicaudal is good to see for its apicaudal is good for you to see the wall circumflex, and epicranial, it's good to see the wall length of the left main coronary artery. Here in this view, we can see the diaphragm. Usually we ask the patient to take breath, but sometimes the diaphragms come in the view, especially in the cranial view. That's here the diaphragm. Just to simplify the view, it looks like a Christmas tree. So then the left anterior oblique with cranial angulation and the left anterior oblique with caudal angulation, or the spider view. The left anterior oblique with the cranial angulations brings the LAD on the midline, and it's good view to see the wall length of the LAD. Here again, the spine on the right hand side, because this is the left anterior oblique, or if we can see we know that the catheter here is coming from the femoral, so in the descending aorta. For the left anterior oblique, the caudal or the spider view, it's a very good view to see the left main. Again, it looks like a spider. That's what the cardiologist, and if this looked like a spider, I'd like to call this the grape pile. It looks like a grape pile for people who like to remember things for the exam. The right coronary artery, we have 2 views, the left anterior oblique and the right anterior oblique. So, and it's very easy to differentiate here, the spine on the right side, the right hand side, so it's a left anterior oblique. Here, the spine is clearly on the left hand side, so this is a right anterior oblique view. And with the right anterior oblique, we extend the PDA to see any lesion. It's advisable to see the lesion in 2 views, not on only 1 view. Here are all the 5 views for the left system. Next step, we go for the management of coronary artery disease. So management of coronary artery disease depends on the stage, the symptoms, and the risk factors of the patients. If the patient has a risk factor for coronary artery disease, we start off preventive measures like diet control, stop smoking, and increase exercise. If the patient on a higher risk of coronary artery disease, we might need to add some preventive measures like aspirin, statins, and ACE inhibitors, in addition to the control of the risk factors. But if once the patient starts having symptoms, in addition to the previous measure, we were going to add anti-ischemic measures in the form of beta blockers, GTN, and reperfusion therapy. And if the patient had acute coronary syndrome, we have to add to all the other measures, again, antithrombotic therapy. Now let's go to the important bit, for us as surgeons, which are the indication of surgery in ischemic heart disease. I'll start with this diagram from the guidelines. So which patients favors the coronary artery bypass graft surgery? So CVG patients with diabetes will get benefit from the CVG rather than the PCI. Patients with decreased LV function, giving in mind the risk factor would be low. If there is a contraindication for dual antiplatelets therapy, these patients will benefit more from coronary artery bypass graft surgery. And if there is a recurrent diffuse in-stent restenosis, so this group of patients also will benefit more from the bypass surgery rather than having another PCI. From the anatomical point of view, the multivessel disease with a syntax score more than 23 is favorable for surgery than the PCI. Also, if the patient has a severely calcified coronary artery that might limit full expansion of the artery using the PCI, this patient will benefit more from surgery. Patients with lesions that are unlikely to be fully revascularized with the PCI should be referred to surgery as well. And if the patient has another concomitant valvular or needs another cardiac surgery, this group of patients usually get benefit from surgery rather than having a PCI. Now let's go for the indication of coronary artery bypass surgery. We'll start with the patients with a low risk surgical mortality. And for the sake of time, I'm just going through only class 1 indication. So patient with proximal LAD stenosis with a one vessel disease are indicated for coronary artery bypass graft surgery. Also, patient with two vessel disease include proximal LAD stenosis. All types of left main are suitable for coronary artery bypass graft surgery. I'm not going in this session with a debate about left main disease, either surgery and the syntax score or a PCI. This is not the subject of this presentation. Patients with three vessel disease, either diabetic or not diabetics, are all indication for cardiac surgery, and they are all class 1 indication for cardiac surgery. Then the indication of cardiac surgery in special circumstances. I would start with patient who has combined coronary and valvular disease. If the patient going for a valve surgery as an AVR or mitral surgery who has a coronary lesion more than 70%, this patient should have bypass surgery in the same setting. If our patient is going for coronary artery disease and has severe aortic stenosis or severe functional mitral regurg with ejection fraction more than 30%, they should have their valvular surgery done at the same session. With patients with ejection fraction less than 35% are indicated for cardiac surgery, giving the fact that the risk would be a low surgical risk. Coronary artery bypass graft surgery is indicated in the patient with a cardiogenic shock as a class 1 if there is no other PCI option. There are many factors that affect the choice of conduit for coronary artery bypass graft surgery. Age is one of them. In young patients, we do prefer to give them more arterial grafts. Risk of sternal infection is another factor. For a patient who had a COPD or immunosuppressed, We usually try to avoid taking bilateral mammary artery to reduce the risk of sternal wound infection. Availability of a conduit is very important. For example, if a patient has a varicose vein or had stripping for the veins for any reason, we can't use the saphenous vein graft. Urgency of operation may play a role. For example, if you have an emergency crushed patient, it's preferred to use veins and rather than using the mammaries. Patient with diabetes mellitus, either to use skeletonized mammary or to use the mammary on one side only. Patient's preference also should be involved in the decision making. Some patients would dislike a scar on their forearm when using the radial artery. And also the degree of stenosis. To use the radial artery, we have to put this artery on a high degree of stenosis to get the best results. Surgeon's experience also a factor. Now I'm going quickly to discuss the advantages and disadvantages of each graft. So for the long saphenous vein graft, it has an 80% 10 years patency. It's available conduit, but on the other hand, as I mentioned, we can't use it if there's a severe form of varicose veins. The left internal mammary artery is a superior graft, has a 95% 10 years patency, but again, when we use pedicled left internal mammary artery, the risk of sternal wound infection is higher. Right internal mammary artery has 90% 10 years patency, but again, sternal wound infection is a risk. The radial artery, the 10 years patency is 80%. The disadvantage is the spasm. It's very liable to spasm and scar. As I mentioned, some patients would not like the arm scar. Before taking the radial artery, we usually do the Allen test in the clinic, and I'd advise to do what's called intraoperative modified Allen test. Simply, after dissecting the radial artery, we ask our anesthetist to put a pulse oximeter on the same hand that we are going to harvest the radial artery, and simply after dissecting the radial artery, we put a bulldog on the radial artery and watch for the pulse oximeter. In this slide, I'm going to quickly review the guidelines, the class 1 guidelines for choice of conduit. The guidelines recommend using the Lima to LAD. It also recommends using the radial artery on a high degree stenosis over the vein graft. And it recommends using the skeletonized mammary if there's a high risk of sternal wound infection. Thank you for watching my presentation. I'd like to thank the SCTS, Egyptian Society of Cardiothoracic Surgery, and Suez Canal University for giving me the opportunity to present in this meeting.